Atrial fibrillation. Definition. Atrial fibrillation, AF, or AFib, is a very rapid, chaotic, irregular, atrial electrical activity. Clinical classification of AF, 5 clinical patterns are described. 1. First diagnosed AF, which was not diagnosed before. 2. Paroxysmal AF, which terminates spontaneously, usually within 48 hours, but may continue up to 7 days. AF cardiovert by treatment within 7 days is also considered paroxysmal. 3. Persistent AF, which lasts longer than 7 days, but less than 1 year. Paroxysms cardiovert by treatment after 7 days are also considered persistent. 4. Long-standing persistent AF, which lasts continuously for 1 year or more, while rhythm control strategy is decided. 5. Permanent AF, which is accepted by patient and physician, while rhythm control strategy is not considered. If rhythm control strategy is reconsidered at any time, AF should be reclassified as long-standing persistent. The clinical pattern of AF may, however, change. Paroxysmal AF often progresses to longer, non-self-terminating episodes. AF initially responsive to cardioversion tends to become resistant. Persistent AF may become paroxysmal with antiarrhythmic drug therapy. Permanent AF may be cured or made paroxysmal by surgical or catheter-based ablation. Sites of origin of AF. AF may arise in any of the following structures. Pulmonary veins, most commonly. Ligament of Marshall. Mitral and tricuspid rings. Atrial walls, commonly left atrial walls. Superior vena cava. Inferior vena cava. Coronary sinus. Crista terminalis. Areas of fibrosis separate these structures from atrial tissues, promoting the arrhythmia. Sites of origin of AF. Pulmonary veins, PV, most commonly. Ligament of Marshall. Mitral and tricuspid rings. Atrial walls, commonly left atrial walls. Superior vena cava, SVC. Inferior vena cava, IVC. Coronary sinus, CS. Crista terminalis. Electrophysiological, EP, mechanisms of AF. EP mechanisms include reentry, automaticity, and triggered activity. Reentry is promoted by progressive conduction delay and conduction block between the sites of origin and the atrial tissues. Automaticity is promoted by markedly reduced refractory period in some areas, which could be due to catecholamine excess, adrenergic AF. Initiating arrhythmia. 2 types of arrhythmias may play a role in generating reentrant AF. 1. Premature atrial contractions, PAC, conducted or blocked, especially when frequent. 2. Atrial tachyarrhythmias, such as atrial flutter and atrioventricular reentrant tachycardia, AVRT. This is a schematic showing induction of AF, following 2 blocked PAC, seen as P waves not followed by QRS complexes. This is a schematic showing induction of AF by a short VA tachycardia. In the first part of the tracing, V waves are seen in the right ventricular apex channel, RVA, followed by A waves in the high right atrial channel, HRA, with VA interval shorter than AV interval, indicating short VA tachycardia. This was followed by AF, showing fibril later EA waves in HRA channel, and irregular V waves in RVA channel. Maintenance of AF. 2 mechanisms may be responsible for AF maintenance. 1. Continuous firing of foci. 2. Atrial remodeling, without the need for continuous firing. When AF is maintained due to continuous firing of foci, ablation of the focus could be curative. On the other hand, when AF is self-sustained due to atrial remodeling, without the need for focal firing, ablation of the focus does not terminate AF, but may prevent its recurrence. Theories for AF maintenance due to continuous firing. 1. Multiple wave hypothesis. In most patients, AF is sustained by wave fronts arising in multiple foci, that collide with each other, and either become extinguished, or divided into daughter wavelets. Atrial tissue cannot respond in a 1:1 ratio, due to very short cycle lengths, very rapid firing rate. 2. Mother wave hypothesis. A single source of impulses, called the mother circuit, fires the wave fronts which break up into multiple wavelets that spread randomly in various directions, that is, fibrillatory conduction, due either to anatomical obstacles, such as scars and orifices, or heterogeneous refractoriness. In conclusion, fibrillation is the result of the following three factors. 1. Firing from multiple foci in most patients, and occasionally from a single focus. 2. Very rapid rate of firing, 400 to 600 impulses per minute. 3. Fibrillatory conduction. Each wave front divides into daughter wavelets, due either to anatomical obstacles or heterogeneous refractoriness. The daughter wavelets conduct randomly in different directions. Maintenance of AF by atrial remodeling. AF, in itself, can lead to atrial remodeling, that is, functional and/or structural changes in the atrial myocardium, favoring its maintenance. Structural changes include atrial dilatation and fibrosis. Functional changes include heterogeneous refractoriness and heterogeneous conductivity. Mechanism of remodeling. Remodeling is probably precipitated by high-rate activity with intracellular calcium overload, followed by activation of multiple subcellular mechanisms. Pathological changes in atrial remodeling include extracellular matrix changes, inflammatory infiltrates, interstitial fibrosis, fatty deposition, and amyloid deposition. Changes in the ion channels. Changes in the gap junctions. Myocyte changes, hypertrophy, necrosis, and apoptosis. Microvascular changes. Endocardial changes. Sympathetic hyperinnervation. Early treatment desirable. Since some of the structural remodeling will be irreversible, early initiation of treatment seems desirable, before irreversible changes occur. Epidemiology of AF. AF is the most common clinically significant arrhythmia. Apart from sinus tachycardia, AF is the most prevalent supraventricular tachyarrhythmia. It accounts for 1/3 of hospitalizations for arrhythmia. Prevalence in the general population is about 1%, increasing to 3% at about age 20 years. Prevalence is generally higher in men and in whites. Lone AF, of unknown etiology and without apparent structural heart disease, constitutes about 20% of all cases of AF. AF is associated with an increased risk of stroke, heart failure, and all-cause mortality. Prevalence of supraventricular tachyarrhythmia among the general population. AF, 10 in 1,000. Paroxysmal SVT, AVNRT, AVRT, and AT 2 in 1,000. Atrial flutter, 1 in 1,000. AF and stroke. The most devastating consequence of AF is thromboembolic stroke. Incidence of ischemic stroke. In AF with rheumatic heart disease, 15% per year. In AF without rheumatic heart disease, 5% per year. In age-matched controls in sinus rhythm, 1% per year. Thromboembolism, in atrial fibrillation and atrial flutter, is due to the very rapid rate of firing, causing stagnation of blood, volume overload, and progressive dilatation of the atria and their venous tributaries, with pulmonary and systemic venous congestion. It is not the irregularity of firing, since thromboembolism occurs in atrial flutter, despite the regular atrial activation in this arrhythmia, while it is not known to occur in multifocal atrial tachycardia, despite irregular atrial activation. Cardiovascular morbidity and mortality in patients with AF. Death, due to heart failure or stroke. Stroke, AF causes 20 to 30% of all strokes. Hospitalization, about 20% of AF patients are hospitalized every year. Left ventricular dysfunction occurs in 20 to 30% of AF patients. Cognitive decline and vascular dementia may develop, even in anticoagulated patients. Quality of life is impaired, independent of other conditions. Etiology and risk factors for AF. Cardiac causes. Age-related degeneration of atrial and conduction tissue. chronic disease, heart failure, chronic coronary syndromes, valvular heart disease, and cardiomyopathy. Acute disease, acute coronary syndromes, pericarditis, myocarditis, cardiac surgery, and presence of predisposing arrhythmia. Systemic causes: hyperthyroidism, acute and chronic lung diseases, obstructive sleep apnea, hypoxia, chronic kidney disease, electrolyte derangement, autonomic dysfunction, alcohol intake, obesity, smoking, and habitual vigorous exercise. Genetic predisposition. AF has a strong heritable component, either independent of concomitant cardiovascular disease, or due to an inherited cardiomyopathy, inherited channelopathies or single nucleotide polymorphisms. Asymptomatic AF. AF can be symptomatic or asymptomatic, even in the same patient. Up to 90% of episodes of paroxysmal AF are not recognized by the patient, including some lasting longer than 48 hours. On the other hand, as many as 40% of patients have episodes of AF-like symptoms in the absence of AF. Who is symptomatic? Symptoms associated with AF vary with ventricular rate, duration of AF, presence and degree of structural heart disease, functional status, individual patient perception, hemodynamic consequences. The hemodynamic consequences of AF can lead to a reduction in diastolic filling, stroke volume, and cardiac output. These consequences are related to loss of atrial mechanical function, irregularity of ventricular response, fast heart rate. These consequences are magnified in the presence of impaired diastolic ventricular filling, hypertension, mitral stenosis, left ventricular hypertrophy, restrictive cardiomyopathy. Symptoms. Patients with AF may complain of palpitations, angina, dyspnea, fatigue, or dizziness. AF with a chronically elevated heart rate can lead to tachycardia-induced cardiomyopathy. Syncope is an uncommon complication of AF, that can occur on conversion in patients with sinus node dysfunction, or because of rapid ventricular rates in patients with hypertrophic cardiomyopathy, valvular aortic stenosis, or with bypass tracts. First presentation of asymptomatic AF may be catastrophic, for example, stroke or exacerbation of heart failure. Quantification of symptoms in patients with AF. The Modified European Heart Rhythm Association, EHRA, symptom score is recommended, which quantifies AF symptoms as follows. Modified EHRA AF score 1, asymptomatic. Modified EHRA AF score 2A, mild symptoms not affecting normal daily activities. Modified EHRA AF score 2B, moderate symptoms that trouble the patient, but still not affecting normal daily activities. Modified EHRA AF score 3, severe symptoms affecting normal daily activities. Modified EHRA AF score 4, disabling symptoms, and normal daily activities are discontinued. Physical examination. The physical examination may suggest AF based on any of the following. Irregular radial pulse. Irregular jugular venous pulsations. Variation in the intensity of the first heart sound. Examination may also disclose associated valvular heart disease or heart failure. Initial evaluation. The initial evaluation of a patient with suspected or documented AF includes pattern of AF, paroxysmal, persistent, etc. Underlying causes. Associated cardiac and extracardiac conditions. Exercise testing. Exercise testing is often used to assess adequacy of rate control with exercise in permanent AF. Reproduce exercise-induced AF. Evaluate for associated ischemic heart disease, which is particularly important if a Class 1C antiarrhythmic drug is used. Ambulatory monitoring. Ambulatory cardiac monitoring may be required for documentation of AF and its relation to symptoms, and evaluation of heart rate control. Insertable monitors. Devices, like the FDA-approved Medtronic Reveal LINQ, have provided long-term monitoring, up to 3 years, for patients with clinical conditions such as unexplained syncope and cryptogenic stroke. It is 1/3 the size of an AAA battery and can be injected under the skin. The subcutaneous ECG signal is recorded with electrodes on the skin surface. A dramatic increase in the detection rate of AF at 36 months was found with the use of such devices. Thyroid function tests. The risk of AF is increased up to 3-fold in patients with subclinical hyperthyroidism. Assessment of the thyroid-stimulating hormone, TSH, and free T4 is indicated for patients with first episode of AF, uncontrolled ventricular response to AF, recurrence of AF unexpectedly after cardioversion, electrophysiological testing. This is rarely required, especially in patients with wide QRS complex tachycardia, or a possible predisposing arrhythmia. Screening for silent AF. Screening for AF seems cost-effective, especially in at-risk populations, such as patients with heart failure and valvular heart disease. Screening can be done by either single-lead ECG, or palpation of the pulse followed by ECG if the pulse is irregular. The following is very helpful in AF detection. Prolonged ECG monitoring in all survivors of an ischemic stroke without an established diagnosis of AF. Opportunistic screening for AF, by pulse taking or ECG rhythm strip, in patients older than 65 years. Short-term ECG recording followed by continuous ECG monitoring for at least 72 hours in patients with transient cerebral ischemic attacks or ischemic stroke. Interrogation of pacemakers and implantable cardioverter defibrillators on a regular basis, for atrial high rate episodes, AHRE. In presence of AHRE, defined as an atrial rate faster than 180 per minute, lasting longer than 5 minutes, further ECG monitoring to document AF is recommended before initiating AF therapy. Additional monitoring with long-term non-invasive ECG monitors or implanted loop recorders should be considered, to document silent AF, in patients with stroke. Systematic ECG screening may be considered, to detect AF, in patients older than 75 years, or those at high stroke risk. Patients with pacemakers and implanted devices. Implanted pacemakers or defibrillators, with an atrial lead, allow continuous monitoring of atrial rhythm, thus, patients with AHRE can be identified. AHRE are associated with an increased risk of overt AF and ischemic stroke or systemic embolism. Management plan for patients with AHRE. Assess the CHADS-VASC score, if anticoagulation is recommended. Verify the presence of AF by ECG documentation as follows. First, review device electrograms if available, to determine whether AHRE is AF or not. If device electrograms are non-conclusive, AF documentation is required by resting ECG, ambulatory ECG recording, patient-operated event recorders, etc. Thus, AF documentation is the first step in management, to decide for starting oral anticoagulation. In summary, in patients with AHRE, no anticoagulation is required when AF cannot be documented with all means of recording and monitoring, or AF is documented but the CHADS-VASC score is 0 in males or 1 in females. Otherwise, lifelong oral anticoagulation is required. Thank you.